So it's our, we really love having a meeting format. We love having the ability for people to unmute and ask questions and feel like we are in community, even though we might not be on Zoom. And then also to be able to get some lively discussion going. And Dr. Stovitz, who's speaking today, is a veteran of having lively discussions. We were just speaking about that. So that's why we chose the meeting format for these seminars. Unfortunately, we had a Zoom bomber last week, and I apologize for anyone who did hear those vulgar comments. We have a team on it, and hopefully it won't happen again. But in weighing the pros and cons of locking down our seminar series, we just felt in the end that community and discussion was much more compelling, and therefore we have chosen again to do a meeting format. But like I said, we do have safety nets in place to try to avoid, or at the very least, handle any Zoom bomber that may come to visit us again. The second announcement, as you can see on your screen, is that we love for our seminar series to be as agile and nimble as possible in order to address the health needs of our communities. And we are a global community, and we're very, very fortunate to have Professor Tatiana Shippey in Health Policy and Management agree to lead a panel to discuss the long view of Russia's war in the Ukraine. Dr. Shippey is a native of Ukraine herself, and she has assembled a panel of academics as well as a community leader who are from Ukraine, who can speak on the personal perspectives and their context in the growing humanitarian crisis. That will not be during our normal seminar time. It will be instead on Monday, April 18th at noon. It will be a webinar, and we will provide the Zoom link in the coming days. So keep an eye on your email out for that. So today, I'm so very happy to have Dr. Steve Stovitz with us, primarily because my conversations with Steve generally begin with, "Hey, Steve, I was playing tennis over the weekend and now I've hurt myself. What do you think?" So I'm much more pleased, I'm much happier to have a conversation with Steve about the academic nature of the topic today. Dr. Steve Stovitz is a professor in the Department of Family Medicine and Community Health, and also an affiliate associate professor here in our Division of Epidemiology and Community Health. He is a family and sports medicine physician who has a master's degree in clinical research. From 2008 to 2013, his research focused on physical activity and obesity, with an emphasis on pediatric obesity. And since 2013, his research focuses now on the study of the best practices in the interpretation and communication of evidence for the purpose of shared medical decision-making. Dr. Stovitz is an associate editor at 3 leading sports medicine journals, which include the British Journal of Sports Medicine, Medicine and Science in Sports and Exercise, and the Journal of Science and Medicine in Sports. And he's also an evidence-based rater for the McMaster University online evidence-based medicine rating system. Dr. Stovitz's clinical practice is just down the street from us in WBOD. He's at the Mill City Clinic in downtown Minneapolis. And he also serves as the team physician for the USA men's and women's national volleyball teams. So quite accomplished. So happy to have you back, Steve. Welcome.
Thanks very much, Ruby and Barb, for helping me out with this. And let me share my screen. Do you all see my screen there?
Yes, we do.
Great, thanks. Okay, let me start my clock here. So I will do my best to leave at least 10 minutes for questions at the end. So my title is about the incorporation of evidence to improve clinical medicine. And I think we need to institute some new rules, new systems. I kind of have concerns that our current system is not working optimally. The evolution of this presentation is that I love working in clinical medicine. I'm in clinic 5 half days a week, which sort of bleeds into about most of the week because of my chart messages and other things. But I have a lot of clinic practice at the Mill City Clinic. I love doing research. I love teaching. Our system makes it super difficult. I know there are exceptions in the system where we have some clinicians who have grants and do teaching and have an active clinical practice, which I would sort of say would be more than 1 or 2 clinic sessions per week. But it's not easy to do that. I've collaborated with many of you in Epi, but not much in the past few years, a lot due to the pandemic. So I talked to Diane and she said, why don't you give a presentation so you can meet people in person? And here we are on Zoom. So there you go with the pandemic. But the clinic is just a few blocks down from Epi. And so I hope you guys stop by. It's a really beautiful place. And I love working there. As far as collaboration, I think on the recruiting front, we could do a lot better than we're doing. We could do a lot more. This is an example of a nice card that Sarah Rydell helped put together with my input. And sort of this is the type cards that I like around clinic. It's either 4x6 or 5x7. It's kind of small, it's sleek. It has the information of what a person needs for a study. It has a phone number so old people can call. It has an email so midlife people can email, and it has a QR code so young people can shine their phones and get into the study. So it's really user friendly. It doesn't clog up our exam rooms. It's not another piece of paper in the exam room, and very easy for patients to take. On the research ideas and design front, I think we could definitely collaborate a lot more, but I think that would require some redesign of some of our systems and well beyond what we can discuss here today on Zoom, but I think that's another huge thing. In terms of my view of evidence and evidence-based medicine, I feel like sort of in a cartoon figure, you know, our evidence comes from you all, it comes from epidemiology, it comes from research, it comes from science. From my understanding of the history, the field of epidemiology obviously is you know, embedded in population decisions in public health. Quite interestingly, I just read the book about the Great Pandemic of 1918, which was actually written in 2005. It's a fabulous read by John Barry. And it sort of explores how basically science moved from snake oil salesman into what we hope is evidence-based medicine through the 1918 pandemic. And but I think so we have these systems in place that work kind of well on a population basis. I'm not sure that we do the best job. Well, I don't think we do the best job on getting that down to individual patient care and shared medical decision-making. The evidence-based medicine calls on us to use the best evidence along with patient values and preferences. I love the mantra. I believe in it. I think we could optimize it. I think the statement is brilliant. But I think we need a few changes on a big topic that, again, is not for today, is that just that we tend to use intention to treat analysis, which tends to be, you know, great for, you know, the effect of implementing something, but for the personal patient who would take or not take a treatment, sometimes intention to treat is not what the patient might be interested in. So for today's talk, I'm just going to discuss some gaps in our current methods of understanding evidence for clinical care. I'm going to share some of my observations and some peer-reviewed research that I've been involved with. The overwhelming goal is to improve patient care. I'm going to use this theme of new rules, which a comedian uses, who I do not agree with on every topic that he discusses, but it just seemed to fit with the presentation. My presentation is not a comprehensive list. I'm not discussing publication or peer review systems or social media and misinformation, misunderstanding of categorization of null hypothesis, significance testing, et cetera. I feel that when I evaluate evidence for patient care, a lot of things sort of become clear to me when I think of things from the patient's viewpoint. So patients come into the clinic and they tend to have a concern. Not always, they sometimes come in for screening, but they often come in with a concern. Do I have something? Do I have COVID? The answer is just an estimation of probability. And the probability is another term for predictive values. Now, I'm not advocating that we tell people you have a 67.3% probability of having the thing. But I do think that if we've gone through medical school, we should be able to have some general idea of what the probability is. We can use terms like yes or no, but we should know that it's just an estimate. If we decide that treatment is an option, I think patients want to know the benefit that is expected from treatment as compared to no treatment. Those things sound super simple and basic, and it's kind of like, duh, of course this is the case. I'm going to show you that I don't know that we're always fulfilling that. So I'll start this by going back to the start of the pandemic, which led to a publication, which led to my discussion with Diane, which led to this presentation. So I was put in charge of a phone triage medical system, which had residents and medical students. And we were set up in the midway section of St. Paul. And we weren't touching door handles, and we were like, it was crazy. So residents would take phone calls from people from the community, and they'd tell me about a caller who would be a perfectly healthy 35-year-old who's developed a cough for the past few days. And I'd say to them something like, what's your estimate for the probability that this patient has COVID? And we'd go through hemming and hawing where they'd use terms like likely or might or could or not sure or whatever. And I'd say, give me a number. And they might say something like 70%. And I'd say, fine, I don't know that we know that number. I'm totally comfortable with whatever number they would have chosen, basically. But then a few minutes later, they would tell me about a different patient who called in with the exact same symptoms, but unlike the first patient, this person has intermittent asthma attacks. And so I'd say, well, what's your estimate that this person has COVID? And they would invariably give me a lower number, like 25%. And I'd ask them, why did you answer differently? And they would not be able to answer in any way that I found particularly articulate. It would be like, well, this person has asthma. I go, I know that person has asthma, but they have the same symptoms as the person that called in earlier. Why don't they both have COVID at the same probability? Now, they don't. I get it. And their instinct was right. But mathematically, they didn't, I feel, have a way to think through it. So medical students are taught that either a positive test means a person has a condition and a negative test means they don't, or they're taught test result interpretation from a viewpoint of sensitivity and specificity without attention to what you would call priors, what I would call pretest probability or prevalence. When we teach medical students, and I don't know how epi students are taught, but we tend to teach from a viewpoint of looking down the path, taking the truth and testing the test. So we speak a lot about sensitivity and specificity. And if you speak to a medical student, they will, those words just roll off their tongue. Sensitivity, specificity, the test was sensitive, the test was specific, whatever. The problem is that when you get to clinical medicine, you look across this table. You get a test that is a result that's either positive or negative, and you have to tell the patient the probability of the disease if the test is positive and if the test is negative. Again, we don't say the probability, but that's the goal. So this led to this paper that I wrote with Ian Schreier from McGill. And we basically took a patient and we asked, does this patient have COVID? And we went through clinical probability formulas. And we tried to show that our 2x2 contingency table that we use in clinical medicine is just a reformulation of Bayes' probability theorem, which seems real complicated, but is kind of not, but we don't tend to teach from that standpoint. And that symptoms and signs are simply tests. Now, this may be very basic to many of you, but I can assure you that this is not the way that clinicians tend to be taught. The next slide is going to be a little complicated. I'm going to walk you through it. So this was by far the most complicated slide I'll have. So this is where we took basically a population of 100 people and who call in with a cough. And what we said is that it's good to think of the cough as a positive cough test. So they call in with a cough. We tend to know the prevalence of COVID in our communities when we're looking at, we can look at population basis and get the probability of COVID in the community. We can also look at studies and get the probability of cough in those with COVID, which is just the sensitivity. And then we have to estimate the probability of cough in the patient with or without COVID. And in this case, we use 20%. The top row here with the plaid is basically people with a cough. The ones in black have COVID, the ones in light blue don't have COVID. The arrow is pointing to the reason why the person without asthma has a greater probability of having COVID than the person without asthma. Sorry, the person without asthma has a greater probability because the person with asthma will have a higher likelihood of having a cough that's not due to COVID. It's that simple. So when you do the math, you want to find out these 8 people out of these 20 people who have a cough. So you've got 8 people with COVID, 20 people who have a cough. What's the probability that the patient with a cough has COVID? And we calculated it at 40%. You can do this by the 2x2 table. We then took these 20 people and we then instituted a PCR test. And on the PCR test, we got a negative test result. So it's down here, the people with a negative test result, which was 2 people out of 13 people. So in our hypothetical scenario, a patient with a cough and a negative PCR test had a 15% probability of having COVID. Now you might say, so what? Well, so what is, at what level are we going to tell people to quarantine or not quarantine, to go to the workplace or not go to the workplace, to be around their family or not be around their family, to visit their loved one or not visit their loved one? We didn't approach it from what level we should choose. We just approached it from, medically speaking, it would be good if we could kind of get to that goal. That was the point of this paper. The issue is that humans, including clinicians, that's a joke because clinicians think they're a little bit above humans. We are just not good at calculating conditional probabilities. And the standard way of teaching doctors doesn't tend to be great. So a classic question in medicine is, if a test to detect a disease whose prevalence is 1 in 1,000 has a sensitivity of 100% and a false positive rate of 5%, what's the chance that a person with a positive result actually has the disease, assuming you know nothing else about the patient? If you do the 2x2 table, 1 patient has the disease, 999 don't. You test positive, the chance that the patient with a positive test has the disease is 2%. This question was first asked, as far as I am aware, at Harvard in 1978, and 18% of physicians and residents got the answer correctly. The test was repeated in Boston in 2014, and 23% got it correctly. I then put together a few grant proposals to try to create an app to teach people about this. I kept getting rejected, and one comment on my rejections was always, clinicians know this. So being the person I am, I decided, as Ruby said, not afraid of controversy, I decided to test the people at the University of Minnesota. And this was a multiple choice test. I gave them options, 5 options, 22% got it correct. So one might say, well, maybe just the terminology is confusing. Maybe if you just put it in English, they would get it right. And this is a classic question from Geiger-Renzer, which is assume you conduct breast cancer screening and you know the following information about women in the region. The probability that a woman has breast cancer is 1%. If she has breast cancer, the probability that she tests positive is 90%. If she doesn't have breast cancer, she'll still test positive 9% of the time. She tests positive. She is the patient. She asks you whether it means that she has breast cancer, what her chances are, what's the best answer. And Geiger-Renzer gave her these 4 options, and the answer is 1 in 10 that the woman has breast cancer. In Geiger-Renzer's study, 21% got it correct. In my study, 29% got it correct. The key thing is I asked the people 2 questions. There was 50 of them. 3 out of 50 got both questions correct. So there's a certain amount of guessing in a multiple choice test. So I published this paper that the inability to calculate predictive values is kind of this old problem that has not gone away. That came out, and then it came out in January 2020, and then COVID hit. And I realized that this pertained to what we were trying to do with COVID. So then I wrote a follow-up paper, which is just that I think we should pick a level for quarantine, calculate the probability, and recognize whether our calculation and our advice fits with our values. And again, I'm totally okay with, I picked a level of 5% and the level is only 2%, but I still think they should quarantine, or vice versa. But I just think we can't have a debate until we sort of have the math fit our value system. So new rule. If you have trouble understanding test accuracy definitions, sorry, I always say this backwards. For those of you who understand test accuracy definitions, you are alone. The definitions that we use are really, I think, super difficult. They're close to intuitive, but just enough off that they confuse people. So if you ask a person on the street or a person in science, sensitivity to most people means a high number of false positives because the test is so sensitive that it picks up everything. And specificity to most people means that if you test positive, it is only for that thing. It's specific for that thing. Not if you don't have the thing, you are unlikely to test positive. And the false positive rate is simply not intuitive to clinicians. So to show how this is important, in the field of sports medicine, which I used to work a lot in, I still work in some, there is a huge debate about doing electrocardiograms as part of pre-participation physicals. And this would be to screen kids at risk for sudden cardiac death, which is obviously sudden cardiac death. There's a huge debate. The people in Seattle think we should screen everybody with an EKG, and I think the repetition they argue is every 2 years. That's a huge cost to society. The rest of the country was not so sure. We're going to screening, by the way. This is the way it's becoming in a lot of places. I was the presenter at an annual meeting for fellows in sports medicine. These are people who went to medical school, residency, and got into fellowship, which is 30% of people who apply. So this is the top of the top, okay? And the presenter after me was one of the authors on this paper about the accuracy of EKG testing. And in the paper, it said that there's this huge debate, but the false positive rate tends to be high. They then say that more recent studies applying modern EKG criteria to screen athletes have resulted in a substantially lower false positive rate, as low as 2 to 5%. So before the co-author is a friend of mine, and again, I'm not one to shy away from controversy. So I said to him, I showed him his article and I said, you had the false positive rate of 15%. You now say you can get down to 5%. I don't doubt that. I just don't think people understand the false positive rate. And he said, well, I think they do. So I put in this slide, and basically it's a 2x2 table. And we all would agree that if you test positive, but you don't have the disease, it's a false positive. And then I just asked the fellows there, what's the definition of the false positive rate? Is it the false positives over all of the positive tests? Or is it the false positives over everybody without the disease? And it was just, they had two choices. They wrote it down. The other guy collected them and told me, and basically the answer is B, and 40% got it correct. So 60% got it incorrect, and there was only two choices. The clinically important point of this is that if sudden cardiac death is 1 in 200,000. If you use the correct definition, even if we get the false positive rate down to 5%, a person with a positive test has the condition less than 1 in 100 times. If you use the incorrect definition, then you're telling a patient that they have a 95% chance of sudden cardiac death if they have a positive test. That's a huge difference. The New York Times had this big article about when they warn of rare diseases, these prenatal tests are usually wrong. Really good article, January 2022. Basically, there's a lot of prenatal tests that'll claim, super high accuracy, 99% sensitivity, 99% specificity, whatever. And then a patient with a positive test, they have lots of vignettes of women going for abortions and other things because they thought that a positive test meant that it was pretty certain that their fetus had something. And of course, the probability was quite low. The only thing I didn't like about this article is it kept sort of blaming the test, but it's really the interpretation of the test that is the problem. And just people are not good at conditional probabilities. This issue of false positive rates in the American Family Physician, their lead epidemiologist put out this table about antibody testing for COVID, false positive rates by population prevalence. And they had this where it went from 80% to 44% to 27% was the false positive rate. That's not correct. They were false positive rate should not change based just on prevalence. So Ryan Demmer and myself and Josh Thompson wrote this paper about beware of the differing definitions. Their answer to us was as follows. The false positive rate, they agreed, is commonly calculated as B over B plus D, which is this way, which Dr. Stovitz and colleagues point out is the converse of specificity. Then the authors wrote, there is no commonly used term for false positive rate. There is no commonly used term for false positive rate, which is this one going across. So we took the liberty of calling it a false positive rate. So there's an old rule, which is that many controversies would soon be ended if those engaged in them would first accurately define their terms and then rigidly adhere to their definitions. If we are using two different definitions for the false positive rate, we are going to get markedly different probabilities. We tend to screen things that are rare, so the differences are not subtle, they're large. So why is this important? If a clinician cannot understand the information, how can they share the information with a patient so that the patient may make a educated shared medical decision? I have this other part about how we are no longer in our silos. I am currently teaching an undergraduate course in the philosophy of medicine, and I taught it 2 years ago, and then the pandemic came out. We took a year off. We're teaching it again. Basically, nowadays, things that are published in epidemiology are read by everybody, right? I mean, it's all online. Anything that has the word COVID in it gets published online right away. So it's no longer like where a person can say, well, I wasn't writing for your audience. I was just putting in terms that my audience would understand. These things are getting misinterpreted. So this is why it's important. My suggestion for teaching is to start our sentences with the word among. So I think people need to center themselves on the population of interest. So sensitivity is among those with disease, the probability of the test being positive, and specificity is among those without the disease, the probability of the test being negative. This not only gets people to say the right definition, but it gets them to understand why sensitivity and specificity don't give the patient the information they want, because if we knew whether they had the disease or didn't have the disease, we wouldn't do the test. Positive predictive value is among those with a positive test, the probability of having the disease, et cetera. There's this mnemonic that's a lot of people teach from. I don't know whether people on this thing do or call do or not, but the medical students are taught spin and snout, which is a test with a high specificity, a positive test rules it in, and a test with a high negative, high sensitivity and negative test rules it out. These mnemonics are great mnemonics in that the students remember them. I think they're bad mnemonics because the students remember them, because I think it confuses the students. That's just my belief, and I'll show you why. So as I referenced earlier, we test for things that are rare. So spin fails because we don't rule things in. And an anxious person may still feel anxious with a negative test. And telling a patient that you've ruled it out is not true. And it can be anxiety provoking. I've ruled out that you have skin cancer. When do we rule out something? Like, we don't rule things out. We assess them. It's a low risk. And saying you can't rule out the possibility of something becomes unintelligible and epistemic injustice in the clinic, in my opinion. This is something with a prevalence of 1 in 1,000, and I would argue that we screen for things that are 1 in 1,000. In the athletics department, we screen for sickle cell trait. These are kids, many of whom at the University of Minnesota have no relatives with sickle cell anemia. They were born in our country. They've therefore had sickle cell testing when they were born. So, even if you assume 100% sensitivity and 99% specificity, a positive test will be wrong over 90% of the time. Can we really say that a test with a high specificity, a positive test rules it in when it's true in less than 10% of the time? Moving on to treatments. Research finds what you all do. We tend to test things and we say that something is better than something else, better on average. My new rule is that when comparing treatments, there is not a single number that gives patients enough information for the patient to make an educated decision. Again, put yourself in the seat of the patient. Okay, if you tell a patient that they should take a treatment because their treatment would lower their risk by 33%, we would all agree that that is not informative enough without knowing the baseline risk. Okay, this is the old Lipitor ads, which were in magazines, and you lower the risk by 30%, but the risk was 1 in 10,000, and so then it's 1 in 30,000 or something, or whatever the math comes out to be. But so many argue to use the absolute risk difference or the number needed to treat. So what if your clinician told you you should take a treatment because the treatment would lower your risk by 10%? Wherever you are, it'd be 10% lower. I would argue, and wrote this paper, that that still doesn't give the patient enough information to make a fully informed decision. So this is a very theoretical imagination exercise, but assume that a person had two conditions that would affect their quality of life equally. So they have either patellofemoral knee pain or thumb arthritis. And treatment reduces the risk of a lifelong problem, but you can only treat one. And that would reduce the chance of that problem by 10% as an absolute risk difference. I understand that you might say to yourself, what if the patient's a runner, then they'd want to treat the knee pain. I'm assuming that for the patient, these two things, they're a weekend warrior runner who's a computer programmer. So they use their knees and they use their thumbs. You know, it's the same to this patient. If you treat, in this case, the patellofemoral syndrome, the chance of a lifelong problem goes from 55% to 45%. If you treat the thumb arthritis, the chance of a lifelong problem goes from 10% to 0. If you can recall those old experiments that we learned about in psychology classes of the risk of people when they have a fear of getting shocked in a psychology experiment, stress goes up really high when it's uncertain whether you're going to get a shock or no shock. So this change from 55% to 45% in our brains is not a huge change, but this eliminates risk. So many would opt to choose the to treat the thumb arthritis. Different scenario. Slightly more serious than patellofemoral knee pain and thumb arthritis, game of Russian roulette, okay, just for fun. Imagine that there were 6 chambers, and the question is, would you pay more money to remove a bullet if the gun had only 1 bullet in it, or if it had 4 bullets in it? Removing a single bullet reduces your absolute risk of death by 17% because there's 6 chambers. So when I ask this, and I'm in person with people after I did the previous one where you want to get to 0 risk, many choose the gun with only 1 bullet. And then I say, well, if you wouldn't pay more if it had 4 bullets, how much would you pay if it had 6 bullets? Your money is worthless when dead, okay? Now, that sounds very theoretical, but this gets into differences when people are facing really bad outcomes. When people have cancer that is got a super, super, super bad prognosis, and you could increase their chance of living by 10%, they will, in my opinion, often be much more likely to take treatment than if the cancer only has a small chance of progressing and you could reduce the risk of death by 10%. So this does correlate to issues we face in medicine. Many of you have probably seen this. If patients are faced with people are faced with a choice of either getting $3,000 or an 80% chance of $4,000, most people choose to take the $3,000. I've asked this question hundreds of times. It's pretty much 100% of people. And if you ask people that, which would you choose to either lose $3,000 or have an 80% chance of losing $4,000, most people will choose the 80% chance of losing $4,000 rather than the certain thing of losing $3,000. So they choose the $3,000 gain and the 80% chance of the $4,000 loss. Both of those choices are the inferior choice on average, but people respond to gains and losses differently. So they're risk averse when it comes to gains. So they choose the certainty of getting $3,000 over the 80% chance of getting $4,000. And by the way, the 80% chance of $4,000 is an average of $3,200. So if you did a study, that would be the superior choice. They're risk seeking when it comes to avoiding losses. They don't want to have losses. So they choose the 80% chance of losing $4,000, 20% chance of losing nothing over the certainty of losing $3,000. How does this pertain to medicine? Many of our treatments have losses. They are certain losses. When I say certain, not, well, losses with certainty. If you choose for surgery, you are going to not be able to eat overnight. You're going to have pain. You're going to spend money, time. You're going to miss work. You're going to have nausea. You're going to have a scar. If you opt for treatment with medications, you need to take a treatment every day. Plus, it can cost you a lot of money. These are things people want to avoid. They're not considered side effects, so they don't show up in studies as side effects, but people would want to avoid it. A few years ago, what this means clinically is that we can't just do arithmetic with the number needed to treat and the number needed to harm. A few years ago, there was the debate about using aspirin is a debate that's gone back and forth, and we were all giving aspirin about 10 years ago. And then in 2016 was when we started to think, well, maybe not. And now it's definitely on the way out more. But there was an article written where the proponent in JAMA said that we should calculate the number needed to treat for an aspirin to prevent a stroke, and then do arithmetic with the number needed to harm, meaning aspirin causes bleeds. And if the NNT was less than the NNH, then they'd recommend treatment. And if the NNT was greater than the NNH, then they'd say don't treat. There's two problems with this, and so we wrote a letter about this. Number one is it assumes that people value strokes and bleeds the same. And it's really interesting when it comes to strokes and bleeds. Patients value avoiding a stroke more than they value avoiding a bleed. Physicians are the opposite way. So you can't make them equal because they're different. Plus, it assumes that people value losses and gains equally, and they don't. They want to avoid taking the pill, having to remember the pill, and causing a loss greater than they value getting a gain. And finally, last new rule. For either diagnosis or treatment, I think it's finally time that we start teaching clinicians to think causally. I understand it's not perfect, but I'd like to ask what we have now and think about whether it's better. And I think if we view things from the clinician-patient viewpoint, this may help clarify evidence that appears confusing on the surface. The area where I've published the most in the past few years is on selection bias, and I presented here in 2018 on what's called the obesity paradox. And what this is that obesity, and when I'm using this term, this just means a BMI over 30, and I didn't coin the term. This is a term that's out there in the literature. High body weight causes problems such as heart failure, yet when you take people with heart failure who have the high body weight, they do better than those who don't. The results are actually completely logical. It's the interpretation of the results where people get confused. And as you can see, my presentation and publication had a great effect on things. We did this in 2018. There was about 800 publications, and now there's over 3,000 publications. There's about 5 to 10 every week. So evidence at its core is relationships between variables. And I think we need to ask, why are things related? And I think that simply stating correlation does not equal causation is not enough. I think we all learned that when we were growing up, and it's true, but it's not enough. And so we all are familiar with confounding bias. I think that selection bias, which is what's the issue with the obesity paradox, where the obesity high body weight causes the heart failure, and you also get to a path of the death with the heart failure and other things causing, not death, the other things causing heart failure, and these things become related inversely. And this issue of collider bias, which is obesity causing heart failure, but then the people in the studies who are not obese having other things that cause their heart failure, which are worse. And so they die more readily of those other things. I feel that this is like kryptonite to evidence-based medicine. I think it breaks through the walls that we have set up So the standard evidence-based medicine pyramid puts meta-analysis and systematic reviews at the top, and there are many meta-analysis and systematic reviews that continue to discuss that there's an obesity paradox. There are randomized controlled trials that show that intentional weight loss is good for you, but again, that's not the top of the pyramid. And if you use the Bradford-Hill criteria, the obesity paradox fits many of these. It's consistently seen. There is temporality. It's plausible. You can make an argument for it. And so it meets many of these things. So I think it breaks through our current method of assessing evidence. This leads to this confusion leads to torturous explanations. So this is what happens when researchers talk to clinicians, but don't think about the patient. Okay, so this was, there's many examples, but I like this one the best. This is an article that's trying to assess whether the obesity paradox in heart failure is a statistical artifact or an impetus to rethink clinical practice. And this was their summary. In any event, a clinician who counsels an obese heart failure patient to lose weight is not directly inducing weight loss per se. Rather, the clinician is leading the compliant patient to initiate an attempt at weight loss. The obesity paradox literature does not, to our knowledge, provide any direct and compelling evidence contradicting such an attempt. I have no idea what that means. The best I can tell is that I am supposed to counsel a patient to lose weight, but hope that they do not. Now, not only is that torturous logic, in my opinion, but in fact, bariatric surgery has helped people with heart failure. Now, some people get sick and have problems with the surgery itself, but if you get past the surgery, I think it's undoubtedly beneficial. It's just the surgery is a risk. So even that's not the clinician inducing weight loss per se, that's actually the clinician inducing weight loss. And that helps. So anyway, I think if we think of what we would say to a patient, we would understand why the problem, why the whole thing is completely illogical. Because if you talk to a patient, you would find yourself saying to them, I have some bad news and I have some good news. The bad news is that you have heart failure. The good news is that you're not as unlucky as the unfortunate guy in the next room who has heart failure and a normal BMI. You'd realize that these studies are not discussing any particular patient. There's not exchangeability between the groups. The people in the groups with the normal BMI are not the same as the people in the groups with the high BMI. They have another cause for being in the study. That's the problem. And you'd realize it if you'd look at it from a patient point of view. So last slide, and then time for questions. I think that many pitfalls in our modern medical education and our problems with incorporating evidence become clear if you assess it from the patient's viewpoint. I think patients need to know the probability of illness, and that telling them the accuracy of the test in terms of sensitivity and specificity is not enough. They will get confused, the clinicians will get confused, and we need to teach that pretest probability is absolutely essential, and we're not doing that right now. For treatment, I think patients need to know the risks without and with treatment, and no single number gives enough. And I think we need to start to learn to think causally, which we could help distinguish information that is helpful for prognosis, another word for diagnosis, and information that is helpful for treatment. And with that, I'll say thank you. And I think we have 10 minutes or so for questions, Ruby.
Thank you so much, Steve. I mean, I think I'm rethinking how I approach these topics in our concepts epidemiology course at the undergraduate level. So, because half of my students in the concepts course at the undergraduate level are intending to become clinicians of some type. Primarily, they're pre-med. However, all of the other clinical fields are represented as well. So this is incredibly important, and really, like you're describing, a shift in the way that we should approach it, even from the beginning years. So let's open up for questions. If anyone has a question, please feel free to unmute. If there are a lot of us, we might do raised hands, but right now I think we can just simply unmute. Diane.
I don't want to divert the conversation, Steve, but I do feel like I need to publicly say that we would not use the term obese to describe someone right now.
I completely agree with you, Diane. So,
Diane, what are we using instead?
Yeah.
Well, I would use a term such as at higher weight status or living in a larger body.
So two things about that. One, Diane, I think I did that after I defined the thing. I kept saying high BMI, but I apologize if I didn't. Two is our electronic medical records when a patient with a high body weight comes in for an ear infection, it asks me, do I want to put, and it uses that term into the diagnosis because I'm not, anyway, it throws the term, we got to get that out of EpiCH. So.
Absolutely, because that's leading to poor. I know that wasn't the point of your talk.
Yeah. Let's get it out of EpiCH. I'm with you.
Systematic changes, absolutely. Kate E., I'm gonna ask that you unmute. If not, I'm happy to read the question.
No, that's fine.
Thank you.
I'm thinking as you were talking, first of all, thank you for that presentation. It was very, very interesting. I had asked a question when thinking about positive predictive value. I'm wondering in the context of COVID, is it possible that when we're talking about asymptomatic COVID, that it's actually a false positive either from a PCR or an antigen test?
When we're talking about asymptomatic COVID, is it possible that it's a false positive? Yeah. So I mean, with COVID, it's like super interesting, and Ryan, I don't think is on, but is obviously one of your experts, Demmer. It matters. Are we talking about is the patient symptomatic with COVID or not, or is the patient infectious to other people with COVID? And that's where I think we're getting some false positives. Up to 90 days, we're writing notes for patients who are traveling because they can continue to test positive for a long period of time. But if their cycle threshold is above a certain level, that means they don't have enough virus, we think, to be infectious to other people. So it really is matters which, are you talking about the disease of COVID in the patient or the disease that you could transmit to another person, or simply that you just don't even have it and it's just lingering?
Yeah, that's what I was thinking is like, you just don't even have it. And I was just curious what you think of that, if that applies here.
I think it definitely applies. All of these are based upon picking a gold standard. So the people with the disease have to have, or condition, have to have the condition, and you have to define what the condition is. Is it infectious? Is it carrier non-infectious? Is it symptomatic? So all of them are dependent upon a gold standard.
I would invite Ryan to add anything else if he has anything. Ryan is on today.
Oh.
Doesn't look like he did. Oh, Ryan?
Yeah, great talk, Steve. I agree. Nothing to add at the moment, other than I think it really depends on the goals. There's not one clear answer. So what are your goals and the individual interaction? I did have another question, if I could take them a moment. I just wanted to get into this issue of, the individual versus the population that you highlighted at the outset. And, listening to you present, it seems like we're in this situation time and time again where many of the best decisions related to probabilities are based on the long-term outcomes with many, many trials. What you do in blackjack, if you're going to play for a full weekend, is maybe different than what you do if you're playing two hands. And with the patient and the clinician, you've got one shot. So, I mean, what favors the population obviously doesn't necessarily benefit the patient in any given moment. If you're asked about a very expensive therapy that maybe isn't proven to be economical, but it's not harmful, a lot of people are probably going to take that therapy because why not? Even though in the long term, it doesn't benefit very much at the population level. So I mean, how does this play into the things you're thinking about? It's an impossible question to answer, I know, but I think it's an important conversation. Just curious about your thoughts from a clinical point of view. You know?
Yeah, Ryan, good question. The one caveat I'd say is some medical decisions are not one shot. So if I have a patient who has knee pain and they have a choice between physical therapy or surgery, I would almost consider surgery one shot. Once you have surgery, you do never not have surgery. If you can tolerate, so physical therapy gives you a 30% chance of getting better, and surgery gives you a 60% chance of doing better. We would often read things that would say, thus we recommend surgery. I don't do that. I say, try physical therapy. You're not going to die of knee pain in the next 6 weeks. And if it doesn't get you better, then do it for surgery. So sometimes one of the choices is 2 shots and one of the choices is 1 shot.
Thank you, Steve. Aaron Folsom is here. Hi, Aaron.
I don't have anything negative. I'd like to talk. I'm still astounded that the obesity paradox is circulating out there. People just are not getting it. And it comes back to, how do you communicate this and correct errors like that in medicine? And also, how are you getting things like this into the medical school curriculum? I mean, you understand it, maybe teaching it to the philosophy class, but how do you change the system and communicate and get people convinced?
Well, two comments. One, I have had no success in getting into our medical school. I taught last 2 days ago in McGill's medical school, so I have much greater success at other places. I'll leave it at that. The other issue with the obesity, with the whole kind of high body weight paradox, is that it's really hard to come back because it's such a good story, and it's a captivating story. It's even the term paradox invites more research. More research is needed. So it's hard to fight such a good, such a fascinating thing. There's articles out there called, and Diana, I'm just quoting the article title, Friendly Fat Theory. And it's that fat causes diabetes, but then once you get diabetes, it flips and all of a sudden is protective. Great story. Super intriguing. I don't find it plausible at all, but it's, I don't know what to say.
Yeah. Thanks.
I don't know if I.
So
Steve,
Hey, Russ.
this is Russell. I have a question. Very interesting talk. A few years ago, I was part of a screening study in Quebec for neuroblastoma in infants. And not only was false positives a problem, but we overdiagnosed and treated too many little kids. And we screened nearly 200,000. The question I have, because you touched on it, of screening tests for rare diseases, and the one we talk a lot about now is screening of pregnant women for potential genetic defects that are uncommon, to say the least. And what do you do, and how do you think we should approach that? Should we stop screening?
No. Yeah, I don't think so. I really, this is how come I know this talk was to Epi, and it's a lot about educating physicians, but we're all working together now. And what I do, Russ, now is I prepare people. When patients come in, we're supposed to screen everybody for HIV and Hep C one time in their adult life. Many people are at super, super, super low risk for those things. I tell people ahead of time, we're going to draw these tests. I'm just telling you, if it comes out positive, it is probably an incorrect result. So that way I don't have to seem like I'm hemming and hawing afterwards. The tests are what the tests are. They can be 99% of both. we need to be smart enough to know that if you get a positive test, your chance of having the illness is less than 1 in 100, less than 1 in 1,000, super rare, not common. Use whatever term you want to do. I'm not saying we all need to sit there with calculators. It's just like we need to understand the concept that it's not 95% chance of sudden cardiac death if you get a positive EKG on a pre-participation physical in a high school athlete. It's less than 1%, so that would be my suggestion. It's hard to tell people to not screen for things that are so dramatic. I mean, that's a ethical issue, but I think we need to start getting educated on probability theorem.
Thank you.
It's David Jacobs. What do you think about repeat testing? That would greatly reduce the risk of a false positive.
It would to a great extent, David, repeat testing. If the person, if it's in some cases, it has to be a different test. So for instance, with syphilis, there are some antibodies that cross-react with it and they'll keep cross-reacting. So the ideal is to test in a different method. Or in EKGs, people can have a repeated thing that keeps coming up, and keeps being quote unquote a false positive.
Steve, I'm happy to stay on for a few extra minutes. Looks like we have more questions. Is that okay with you?
I just gotta say, I will stay on for as long as you want. This is like the most fun I've had in 2 years. So
Jim has a question, but before that, I want to highlight something Mary Elefante wrote, which I totally agree with. She writes, I think it's having enough respect for the patients too, believing that they will understand ambiguity.
Yes, and we hear a lot about patient, whatever it's called, illiteracy, or not, mathematical or statistical illiteracy. I mean, Geiger-Rinzer's title of his paper was Illiteracy in Patients and Doctors. So I do think with pictures, things like that, people do understand if you practice how to tell people things. I'll make one other comment for the group and then answer Jim Panko's question. A small little thing, people understand numbers better than they do percentages. So the one that I always use to people is, what's 0.1%? David Jacobs knows that's 1 in 1,000. Even David Jacobs probably picturing 1 in 1,000 is a greater visual representation about what 0.1% is than 0.1%. So I think we should tell people 13 in 100. That's what I do with statin treatment. You have a 12 in 100 chance of having something in the next 10 years if you don't take a statin. If you do, you have an 8 in 100 chance. Would you like to take a statin? To me, that's more than 12%, 8%. It's too much math for people. Why make them divide? Jim Pankow, sorry.
Yeah, Stephen, really terrific presentation. It made me think a lot about some of these things. My question has to do with communicating things like predictive values and calculating conditional probabilities. So with something like COVID, all clinicians were new to it in 2020 and sort of starting at the same place. But for most of the things that you diagnose and treat, they've been around forever. And so my question is it a good assumption that clinicians like from your cohort who have a great deal of experience with patient care do better with these concepts and communicating them with than new physicians do?
Almost the opposite. I think that older physicians get really comfortable with their patterns of practice. And what happens, Jim, is I do think that in many cases, it doesn't matter. I work with John Hallberg and I mean, some great physicians who don't think as mathematically as I do. And I think if you're, raised well by your mother and you've got good interpersonal skills and you understand human nature and you've traveled and you've got experience and you're humble and you learn from your mistakes, you develop really good patterns. I mean, it's for the people who are not good at that. And that's the people we need to teach. And I find that these concepts are way easier to teach high school students than they are to teach fourth-year medical students. Because I've gone to my son's high school class and they haven't learned it the other way yet. I don't know if I answered your question or not.
Yes, you did. Thank you.
Are there any more questions?
Just a small comment.
Hi, Henry.
I see. You've dealt with the physician problem. You haven't considered the epidemiologist problem and our use of risk ratios and relative risk rather than absolute risk. And it's the same sort of phenomenon.
Henry, as always, I agree with you. And I would never come up here and, I'm not going to, I'll criticize the physicians. I'm not going into a group of epidemiologists and criticize epidemiologists, but yeah, relative risk to a patient. Yeah.
Great to see you.
Good to see you.
Well, Steve, thank you so much. You can tell by the comments that everyone enjoyed your talk. And I think we have a lot of future discussions to hold here, either with our graduate program leads or even some of the undergraduate, if not high school leads. So I appreciate your time with us and I look forward to working with you in the future.
Great. Thanks for inviting me, Ruby, and Diane and Barb helping out. Good to see everybody.
Thanks, everyone. Bye-bye.
Bye-bye.